It's been more than 30 years since a drug was approved by the FDA in this country for scabies. So our treatments really haven't evolved as we have increasing understanding of the disease and increasing understanding of the limitations of our currently available therapies. Why is control of scabies so difficult to achieve? Well, we've discussed several today. There can be a delayed diagnosis or a misdiagnosis altogether, which then is going to propagate the infestation to close contacts. Inappropriate medications may be used, or we may prescribe the right medication and it may not be used correctly by the patient. It could be overused, it could be underused, or maybe they're not treating all their close contacts as instructed, and that's when we get into the trouble of reinfestation, which is a real problem with scabies infestation. Also, we have to consider resistance of the mite to the existing products we have available to us. This quote by Gopinath in 2018 is really very accurate. The existing scabicides have variable drawbacks, including toxicity, adverse events, limited safety data in key groups, the emergence of resistance, and treatment failures. Thus, the lack of an ideal acaricide makes the search for novel agents critical. And we all agree with that. We really need to see something new in the scabies treatment landscape. So how can we overcome some of these challenges? Well, one is doing what we're doing today. Education on just scabies as a disease state, recognition of the disease, the clinical lesions, and when to consider the diagnosis, and then how to make the diagnosis, or at least to treat effectively empirically. Second, though, would be the development of novel targeted topical therapies. Remember, targeted therapies are all the rage right now. If we think about diseases such as atopic dermatitis, psoriasis, inflammatory bowel disease, rheumatoid arthritis, lupus, there are many others, we're really seeing them treated with more targeted therapies, which tend to have high efficacy, good safety. They're more targeted to specific molecules or organisms, and they tend to be less prone to the development of resistance. So selectivity is really the key for us to have an agent that has optimal efficacy and safety and is a new therapeutic option. Now, it's important to consider the FDA's newer approach to testing for potential new topical therapeutics. A recent systemic review of randomized trials showed that the existing scabies agents that we have really lack standardization. They may have had low enrollment numbers in the clinical trials. There were risks such as investigator bias. And importantly, we haven't had any newer agents, so they haven't followed the FDA's newer draft guidance to drug makers when they assess the development of topical therapeutics. And these include the things found in the blue box here. Static scales should be used to evaluate cutaneous signs, which may include a variety of things like erythema, edema, papules, erosion. Use patient-recorded outcome measures that are used now in all clinical trials virtually to help assess symptoms. In this case, it might include pruritus, pain, sleep disruption, burning. Plan the timing and frequency of assessments to identify anticipated reactions, and then characterize suspected adverse reactions. And the FDA is very picky now with topical therapeutics that we look for allergic or photoallergic contact dermatitis, which means that during these clinical trials, there has to be specific testing to assess for those types of reactions. So there really is a need for more effective therapies for scabies that would meet the updated FDA's safety and tolerability standards for topical therapeutics. What would be the properties of an ideal targeted topical therapy? So the ideal therapy would recognize a specific target. It would be active primarily at that target site and not just surrounding tissues. It would avoid safety and tolerability issues that may be associated with agents that have to be systemically absorbed, especially those that have potential toxicity, like neurotoxicity we talked about earlier. It would avoid fluctuations in drug levels. It would be such that there was no increased risk for drug resistance. And it would be really agreeable, easy to use, easy to apply, and available to our patients. How about a targeted topical therapy for scabies? What would that look like? Well, we'd want a drug that really has high selectivity for the scabies mite and is highly effective against killing it. One that really, if possible, could stay where we want to apply it, where we want it to have its action and not penetrate into systemic circulation. It'd have to have a good safety and tolerability profile, be convenient to apply, and resistance would hopefully not be a concern. So here's a video cartoon again, looking at the ideal topical agent. It's in white. You would apply it to the skin. It would be specific there, killing the scabies mite specifically. It wouldn't penetrate deep into the skin or penetrate systemic circulation, and instead would remain as a depot on the skin surface where it was sloughed off as we went through the normal process of skin desquamation, as you can see here in the cartoon.